Hello everyone and welcome to a new session of cardiovascular clinical pharmacology. Today we are going to speak about agents used in dyslipidemia or antihyperlipidemic agents. I am Dr. Khalid Hassan, Associate Professor of Clinical Pharmacology, Drug Therapy and Clinical Research. So, as it's known that hyperlipidemia, known as dyslipidemia, a new definition may be defined as elevated total cholesterol, LDL cholesterol, triglyceride, or reduction of HDL cholesterol. Could be one of these: elevated cholesterol, or elevated LDL cholesterol, triglyceride, or reduction in HDL cholesterol concentration. And in some cases, we can see the combination of these abnormalities. The important issue here with this case that most patients are asymptomatic for many years. That means patients suffer from hyperlipidemia without symptoms for many years. But patients may come to the clinic or to the hospital due to the complication of dyslipidemia or hyperlipidemia. Dyslipidemia can lead to the symptomatic vascular disease, atherosclerotic cardiovascular disease. As you can see here, we have ASCVD, stands for atherosclerotic cardiovascular disease. So if we left dyslipidemia or hyperlipidemia without treatment, this will lead to the atherosclerotic cardiovascular disease. What we have here, this slide here present the diseases or disorders related to the dyslipidemia. Patient with dyslipidemia may suffer from coronary artery disease, stroke, peripheral artery disease, PAD, acute pancreatitis, the acute pancreatitis is mainly related to the hypertriglyceridemia. Triglyceride level high here in the acute pancreatitis could be very high also. A patient may suffer from hepatomegaly, eruptive exanthomas, and corneal arcus. So when you talk about hepatosplenomegaly, meaning the enlargement of the liver. So during the clinical examination, you can feel the liver and maybe extend beyond the ribs. So you can touch the liver by your palpation of the abdomen. Okay, by clicking on this link here to show, to present or show lipoprotein, because in the blood we have in the blood cholesterol, we have triglyceride, we have lipoprotein, which means like a component that carry all these particles. So we're going to share the screen from the website. Okay, so you can see here on the screen the lipoprotein molecules. This is a lipoprotein. You can see on the lipoprotein we have on the inner side and the core side we have triglyceride. In the core, in the center, we have triglyceride. Then we have cholesterol ester. On the outer side we have apolipoprotein. Then we have phospholipid. We have unesterified cholesterol, and this is considered like free cholesterol. Then we have another ibuprotein P100. So you can see the molecules. These molecules circulate in the blood. Could be VLDL, could be LDL, could be HDL. Okay, moving to the relationship between the triglyceride and cholesterol rich or apoprotein. Okay, if you click on the link here, okay, this is another article published in the Journal of Lipid Research. I will share the website with you. This is from the website, and the title for this article, Hypertriglyceridemia, Cardiovascular Risk. And we are not going to discuss this article, but I'm going to share with you the image published in this article because it's very related to our okay, so you can see here we have different type of apolipoprotein. I will click on the large image here, make it large. Okay, so you can see here we have chylomicron, then we have VLDL, then we have IDL, we have LDL. And the purpose of this slide here to show the type of triglyceride, the triglyceride in the blue color and the cholesterol in the yellow color. And here we can answer several questions. For the chylomicron, the majority of the chylomicron triglyceride, and we have very tiny, small percentage of cholesterol, the yellow portion. Moving to the VLDL, now we still have the main portion of the VLDL lipoprotein. The main portion, you can see it here, coming like related to the triglyceride, and we have around like could be between 20 to 30% cholesterol, the yellow portion, VLDL. If you move to the IDL, it's very similar, still with the majority of this particle to belong to the triglyceride. But can we look together on the LDL? On the LDL, you can see there the majority of the particles or this lipoprotein, the majority of this lipoprotein is cholesterol, and we have a small portion of triglyceride. This is important topic for the lipoprotein, and they also try to tell us what type of apolipoprotein available on each lipoprotein. For example, if you look at the LDL, on the LDL particles on the surface, we have apoprotein ApoB100. ApoB100 could be target for our treatment. Okay. Next, we have lipid profile. Lipid profile here is important to determine the risk of atherosclerosis. So high cholesterol level, often significant risk factor for developing cardiovascular disease. I'll repeat that. High level of cholesterol are often a significant risk factor for developing cardiovascular disease. So when you have patient with a high level of cholesterol, this patient may predispose to the developing cardiovascular disease. Here we have to be familiar with the lipid profile, lipid value. We look on the LDL cholesterol, what is normal, optimal, borderline, high, or very high. The same will be applied for the HDL. We need to know the total cholesterol normal value. When we are going to consider the total cholesterol high, the same will be applied to the triglyceride. So I will start with the first one. So when you have patient with the LDL level less than 100, this is the optimal. This is the ideal value for LDL. The LDL should be less than 100. Next, if the LDL between 100 and 129, near optimal, we accept that. We recommend patient to do some lifestyle modification. Then we move to the LDL value between 130 and 159 milligram per deciliter. We consider this one like borderline, borderline to high, 130, 159. Okay, patients suffer from high level if the LDL value between 160 and 189. Okay, very high, more than 190. So you can see here we have different range for LDL level: optimal, near optimal, borderline, border high, high, very high. So the most important one we need to focus on, okay, we can look on what is the optimal. For example, the optimal should be less than 100. If the patient comes to the clinic with a LDL more than 120, this is considered like very high level of cholesterol or LDL cholesterol. Moving to the HDL, this is a bad cholesterol. We call this one, so many textbooks call the LDL like bad cholesterol. This is the good cholesterol, the HDL. The best value for the HDL, they said to be more than or equal 60. But if you look on the HDL less than 40, this is a poor value. So normally we look on the patient to be above 40. Above 40 to above 60, that will be good. So HDL, we need HDL to be high, above 40, and if the patient 60, 50, 55, 60, that's great. So we need the HDL to be high level of high normal. Moving to the total cholesterol, we need to remember that value. Total cholesterol, this one should be fasting 12 hours. Only water allowed during this fasting. The total cholesterol normal value should be less than 200. borderline 200 to 39. High cholesterol, total cholesterol considered high if the patient blood test for cholesterol more or equal to 240. So please remember the normal for cholesterol less than 200. If the patient above 240, this is considered high. Triglyceride level normal less than 150, less than 150, high 200 and 499. And if the patient equal or more than 500, this is very high. So we need to remember 150 normal, less than 150 normal, 200 499 high, very high, more than or equal 500 milligram per deciliter for triglyceride. This value is very important when you treat patients suffer from hyperlipidemia or cardiovascular disease associated with hyperlipidemia. We need to remember all these numbers here. So here we have questions. Patients with the elevated cholesterol present to the ambulatory care clinic for treatment of abnormality of cholesterol. Which of the following patient best benefit from the treatment of statin or HMG coenzyme A reductase inhibitors? So select all that apply. That mean could be more than one answer or could be one answer. Correct. So the patient here come to the clinic and we have the lipid, we have the blood test here, and we ask the patient which of the following blood lipid profile we warrant the treatment for with the statin here. Okay, I will start with the first one. If the total cholesterol 180 and LDL 75, HDL 50, do you need to treat this patient? Okay, so do you need to treat this patient? 180, 75, 50. No need to treat. This is all these normal value. 180, 180 cholesterol, 88 LDL, HDL 55. No need to treat this patient. All normal. All the value here is normal. The same, normal. Okay, C, total cholesterol 180, LDL 99, HDL 45. It's normal, no need to treat. Okay, I will move to the D, option D, total cholesterol 250. I believe that high, consider high cholesterol. LDL 199, consider very high, and we can draw two arrows, very high. HDL 45, this is normal. This is normal value. Here is warrant for treatment with the statin. We need to treat this patient with statin. Okay, again, 245 cholesterol E, 245 cholesterol, 190 LDL cholesterol 45. We need to treat with the statin here. So the correct answer will be D and E. Okay. Okay, in order to understand the antihyperlipidemic agent or dyslipidemia treatment or pharmacological approach, we need to know the pathophysiology of atherosclerosis, because atherosclerosis is closely related to the hyperlipidemia. As you can see here, atherosclerosis, we need you to able to describe the proposed role of lipoprotein in the formation of atherosclerotic plaques. Here we can see that we have the cholesterol moving in the blood. So circulating cholesterol in the blood plays significant role in the etiology of atherosclerosis. So cholesterol, one of the important molecules in inducing atherosclerosis. Atherosclerosis vascular lesions begin in the presence of elevated cholesterol. So we have elevated cholesterol and we have other atherosclerosis cardiovascular disease. So the patient come to the hospital or to the clinic not only from high cholesterol. We have other risk factor. We have atherosclerotic cardiovascular disease. You can see here the patient may suffer from diabetes, obesity, or hypertension, or smoking, elderly patient, family history. Could be one of these or could be combination of these atherosclerosis cardiovascular disease. So if you click on the website here and this link here, this will take us to another one published in National Institute of Health, and this present the what is atherosclerosis, and I encourage you to maybe review this website. And you can see here, this is a normal artery and artery with a plaque. So you can see the normal artery allow blood to move smoothly inside the lumen. Okay, you can see here we have the atherosclerotic, we have the plaques that narrowing the lumen and limited the blood supply. This will lead to something called ischemia. Ischemia could be in the heart. We call this one ischemic heart disease, could lead to the angina, or could be in the brain, and this will lead to the stroke. We have ischemic stroke or ischemic heart disease, or could be in the peripheral arteries and could lead to the peripheral artery disease. So we have several pathological effect of the atherosclerosis. So as you can see here, we have the cholesterol in addition to the atherosclerosis cardiovascular risk factors. Okay, so we have two components, and then we start talking about risk factors. So what happened here when you have cholesterol and atherosclerosis cardiovascular risk factors? So when you have these factors available or accumulate on the blood vessels, this will lead to the damage to the endothelium, damage and break down the endothelium. And this will lead to the LDL particles will be able to enter the endothelial cells. Entering the endothelial cells with this will allow or induce monocyte. Monocyte will follow and oxidize LDL. Now we are going to have oxidized LDL. Oxidized LDL will motivate or will create or induce macrophage, make the macrophage try to phagocyte LDL. So the first one, we have risk factor. Risk factor lead to the damaged endothelium. LDL particle will enter the endothelial cells. This will create type of inflammation. Monocyte will oxidize LDL. Macrophage will phagocyte the LDL. At the end result will be ended up with a dead macrophage, and this dead macrophage called foam cells. Foam cells start release cytokines. Cytokines responsible for formation of fatty streak. So you can see the process here for atherosclerosis. We have several process, several factors integrated in the atherosclerosis. We have fatty streaks. Fatty streaks considered like thrombogenic molecule fatty streaks. The platelet will be interfere. The platelet will begin to gather and damage the endothelium. The platelet will release something called PDGF. PDGF stands for platelet-derived growth factors. So from the name, growth factors. So we have something inside the blood vessel start growing, and we call this one growth factors. And you can see here we have inflammatory agent called cytokine. Then the platelet will release platelet-derived growth factors. The growth factors, from the name growth factors, this will encourage smooth muscle cells to growth and lead to multiply, and the smooth muscle cells start secreting collagen, proteoglycan, elastin fibers, and the end result will be fibrous gaps. So the fibrous gaps will be form in the wall around the fatty streak and preventing blood clotting. So we try to prevent the blood clot. Okay, we have the fibrous gaps here. We have the fibrous gap. I have a picture to maybe I will share it with you soon. Okay, fibrous gap with the fatty streaks. This both of them, two parts. Fibrous gap, fatty streaks called a plaque. The plaques lead to narrow the atrial lumen. So the plaque narrow the atrial lumens. Okay, so what we have else here? We start in the blood. We start seeing the calcium start deposited onto the blood, onto the plaques, and this will lead to the stiffens and hardens the arteries. So calcium plays important role in the stabilization of the atherosclerosis plaques. What else? The immune system will be involved and induce inflammation. And for this reason, patients suffer from ischemia. We can see in the blood test CRP will be high as inflammatory markers. So due to that interfere with the immune system. So they try to maybe remind us, they said atherosclerosis is an inflammatory disease. This is very important. So we have atherosclerosis and the artery, stable atherosclerosis. Okay, what happened here? Fatty plaque will be ruptures. Okay, the fatty plaque will be ruptured, and this will lead to the thrombogenic, and black material get exposed to the blood. So this parts of thrombogenic and plaque will move in the blood, and moving this clot in the blood will lead to the occlude arteries, especially when we talk about small arteries, small artery in the brain, small artery in the eye, small artery in the. So we have so many. So we call this one micro circulation and macro circulation. So what we have here, we have another website to, and we have the YouTube also to watch the process for the atherosclerosis. This article published in Atherosclerosis, Thrombosis and Vascular Biology Journal, 2005. So I'm going to share it with you. Okay, this article published in the journal, peer-reviewed journal, Oxidative, peer-reviewed journal in PubMed, Oxidative Stress and Vascular Disease. I will scroll down, okay, to see the. Give me 1 second. Okay, this article here about reflection on atherosclerosis, lesson from the past and future research directions, published in Duff Press, and scroll down to see the picture for that. So this is the picture here for pathogenesis of atherosclerosis. If you click on this picture here, okay, so you can see the pathogenesis of atherosclerosis. So as you can see, we have cholesterol here. Okay, then we have the monocytes. We discussed the monocyte with you. We have macrophage, monocyte, macrophage, cholesterol, LDL. All these lead to the induced inflammation. Endothelial cells, you can see the damage in the endothelial cells. When you have accumulation of cholesterol, lead to the damage in endothelial cells. And this will lead to the inflammation. Worm cells will be formulated. What happened here? We have cytokine will be released. This is another article for linkage between immune system disorder and atherosclerosis. And if you click on this link here, I prefer to look on the bigger image. You can see the LDL and cholesterol enter the cell, lead to the damage endothelial cell. Monocyte will be interfere. Okay, the monocyte will be tried to oxidize LDL. You can see oxidize LDL, and monocytes start release cytokines such as interleukin 4, interleukin 10, interleukin 13, and this will lead to the activate monocyte, and macrophage will be interfere in this one, and this will lead to the pro-inflammatory disease. Okay, so then what we have here, we have so we have cell death due to the macrophage interact. Okay, we start looking on something else. Do you have something else here? Okay, back to the journal, Oxidative Stress and Vascular Disease again. And this is an article published in Atherosclerosis, Thrombosis and Vascular Biology. I scroll down to see you can see the image. This is the image maybe the best describe the situation or the case. So you can see here we have the LDL, and with the monocyte interfere, we have damage to the endothelium. Then with the interfere with the monocyte tried to oxidize the LDL. Now we have oxidized LDL. Macrophage tried to phagocyte the oxidized LDL. What we have also here, we have platelet release growth factors, and this could be like type of cytokines. Growth factors, from the name growth factors, this will induce the enlargement of smooth muscle cells, growth, multiply of smooth muscle cells. Smooth muscle cells will migrate, will move. You can see smooth muscle cells migration and proliferation will move with the worm cells, with the fatty streaks, all together to form something called fibrous gaps. Now in the blood and in the endothelium we have calcium. Calcium will be interfere also and cause calcification. This will harden and this will make the plaque more tight. That's number one. So we have plaques, but due to the blood flow will hit this atherosclerosis plaques, will lead to the ruptures of these plaques and lead to the formation of thrombosis, small gluttings, and this small glut will move in the circulation, could arrive to the brain and cause ischemic stroke, could arrive to the heart, cause ischemic heart disease. So the previous maybe few slides discuss the pathophysiology or pathogenesis of cholesterol and LDL and the formation of atherosclerosis and cause stroke or ischemic heart disease. Now what we have here, we have another molecules maybe circulate on the blood called HDL. HDL stands for high density lipoprotein. They said HDL present protective mechanism. So HDL, when you have HDL normal level or high, this will protect you from the heart disease. And you can see here several well-documented function of HDL and apoprotein A1. These, remember, HDL and apoprotein A1 have the potential to protect from cardiovascular disease. Potential protection of cardiovascular disease: HDL, high density lipoprotein, and apoprotein A1. Apoprotein A1, HDL protect from cardiovascular disease. We have several proposed mechanism for how HDL protect. They said promote efflux of cholesterol from a macrophage in the arterial wall, which means try to remove the cholesterol from the arterial wall. Try removing the cholesterol from arterial wall, inhibit vascular inflammation, anti-inflammatory effect, antioxidant effect, antithrombotic properties, enhance endothelial function, and here we talk about normal function of endothelial cells, promote endothelial repair, increase angiogenesis. Angiogenesis is a very important concept to protect from the ischemia. Protect from ischemia with promoting angiogenesis and have anti-diabetic properties. So you can see all these factors considered like protective factor of HDL. So the HDL protect from heart disease. HDL protect from heart disease, but LDL cause or involve in heart disease and brain disease. Importance of LDL and the importance of LDL in the liver. So here we talk about the importance of LDL receptors in the liver. So we have LDL in the blood. And when we talk about the liver, they found we have receptor for the LDL. So we have LDL receptor. What that mean here? The liver tried to bind, to bring the LDL from the circulation and bind the LDL. So if you have more LDL receptor, that means this receptor will bind the LDL will bring the LDL from the blood and bind with the LDL and this will lead to the result will be lower LDL in circulation. So when you have enough receptors, that will lead to the lower LDL in the circulation. That's a great concept. I will move to what we have here. We talk about LDL receptor. The LDL receptor are present on the cell membrane on the liver cells. So cell membrane on the liver cells, the LDL receptor, number one. These enable cholesterol to enter normal body cells. So the LDL bind to the receptor, then enter the cells. Once attached to the LDL receptor. So what we have here, we have the receptor here, and then we have the LDL. So the LDL bind to the receptor. So now we have LDL receptor. This is the LDL, and this is the cell membrane. Once attached LDL to the receptor, LDL release the cholesterol and triglyceride. This result here Okay, start releasing cholesterol and triglyceride. The cholesterol is stored and oxidized in the bile acid. This will move to the bile acid or bile salt. Okay. Excess cholesterol in the cells suppresses the formation of LDL. Here we have this one is very important. The last one, the last concept here, they said if we have excess of cholesterol in the cells, we have excess of cholesterol in the cells, this will lead to the suppresses of formation of the receptor. So when you have high cholesterol, this will lead to the, I would say, suppress or decrease formation of LDL receptor. Okay. So what we have here, we need to discuss the LDL receptor and ApoB100. And if you go back again to remind or refresh your mind, what type of receptor we have with the HDL, I will go back to show you what we have. Very important to remember what type of receptor we have. So speaking about HDL, the receptor we have it on the HDL called ApoA1. Speaking about LDL receptors, on the LDL receptor we have receptor called ApoB100 and ApoE. So we have different type of receptor. We have ApoB100 and we have ApoE receptor. So we have different type of receptor. LDL receptor exists in the liver and most of the peripheral tissue. So we have LDL receptor in the liver. We have it in peripheral tissue. The complexes LDL and receptor taken into the cells by mechanism called endocytosis. This is belong to the endocytosis belongs to the pharmacokinetic. Lipoprotein catabolized, releasing cholesterol and amino acid. The LDL receptor is recycled back to the cell surface. Okay, this is another article published in the Journal of American College of Cardiology. The article name is like a new and emerging therapy for reduction LDL cholesterol and apolipoprotein. Moving to what we have here, we have the image. I will click on the image and we have the large. I will maximize the size of this image and try to discuss what we have here in this image. Okay. So here we need you to look on LDL receptor. Okay, so you can see the LDL receptor together. So the LDL the formation of the LDL start from VLDL. VLDL will convert to the IDL, which means intermediate the density lipoprotein. Then we have low density lipoprotein. Low density lipoprotein, LDL, low density lipoprotein will bind to the receptor in the liver. Okay, bind to the receptor in the liver. Then we have the consequences here. Another maybe pathophysiological effect here with the chylomicron. We need to look on this classification and properties of plasma protein, and here it's very important to look on the composition of the LDL receptor. We focus on the LDL receptor mainly. Okay, on the LDL receptor, and you can see here is like considered like smallest size, less protein. It has largest amount of cholesterol compared with other lipoprotein. For example, if you compare that with the HDL, it has 16 for example percent. What type of receptor do you have in the cell surface? Apoprotein B100. If you talk about HDL, we have ApoA1. ApoA1 in the HDL. For the LDL, we have ApoB100. Moving to the next slide, this is very important to show you what we have. We have the HDL circulating in the blood here, for example. We have the LDL. You can see the LDL here, and on the LDL we have in apoprotein 100. This one here, B100, similar to what we have here. B100, we have it here. B100 receptor. And this molecules LDL with the apoprotein 100 will enter the cells with the process called endocytosis. And this explains what happened with the endocytosis. We have another process. Maybe with the endocytosis, this will lead to the release of content of the LDL, such as cholesterol and other content. Okay, so from this slide here, maybe now we understand what happened with the LDL. When we talk about LDL molecules, we have the LDL molecules, and we have a receptor on the cells. This is the LDL molecules. Then we have ApoB100, and then we have another receptors called ApoE receptor. So we have two receptors on the LDL, and you can see the process by entering the cell by endocytosis. We have seen it already, and when this enter the cell, this will lead to the release of content. Okay. This slide here, the purpose of this slide here to show the goals of dyslipidemia treatment, why we need to treat the patient with hyperlipidemia. They said the occurrence of coronary heart disease is positively associated with the high total cholesterol and LDL level. So that when the patient suffers from high level of cholesterol or high level of LDL, this will associated with the increased risk of cardiovascular disease. We have positive relationship between coronary heart disease and elevated level of cholesterol and LDL cholesterol. This is number one. Number two, they found another study found that several research found that high level of HDL, the good cholesterol, have been associated with the decreased risk of cardiovascular disease. So you can see here we have increased HDL, increased heart disease. On the other side, we have HDL. If the HDL high, this will decrease cardiovascular disease. So according to the guidelines, the cholesterol guidelines, the need for antihyperlipidemic drugs should be determined based on the assessment of risk of atherosclerosis cardiovascular disease, in conjugation evaluation of lipoprotein. So we need to do the blood profile, lipid profile, and look and evaluate atherosclerosis cardiovascular disease. Here we have, for example, you found this patient is warrant for the treatment of with the antihyperlipidemic drugs. For example, patients suffer from diabetes, or patients suffer from hypertension, or patients suffer from recent MI, and the lipid profile very high, the LDL high and LDL high and cholesterol level very high in the blood. So now we start thinking about treatment or management, how to treat the patient. Number one, we start with something called therapeutic lifestyle modification, TLC, therapeutic lifestyle changes, such as we recommend patients to follow the healthy diet, practice exercise, reduce weight. All these will help to reduce cholesterol level. So start with the therapeutic lifestyle change. Therapeutic lifestyle change does not replace the need for drug therapy. Okay, so for example, if the patient warrant for the treatment was a statin or benefit from statin. So what we have here, they said a lifestyle change do not replace the need for drug therapy in patients who fall into one of the 4 statin benefit. Here we have very important question. We have a group of people who will benefit from statin. We need to start with statin, and this group of people, 4 group of people will benefit from statin. Don't wait until maybe the patients are from disease. The primary goal of treatment, this is a key word here. The primary goal of treatment for lipidemia or dyslipidemia, reduce morbidity and mortality. Okay, the primary goal of dyslipidemia management to reduce morbidity and mortality, lowering total cholesterol, reduce risk of first or recurrent atherosclerosis cardiovascular disease event, So lowering cholesterol level will reduce risk of myocardial infarction, reduce risk of angina, reduce risk of heart failure, reduce risk of ischemia, ischemic stroke, reduce risk of peripheral artery disease. It's very important to start treat a patient with lowering agent, with lower cholesterol agent such as statin, because this will prevent from cardiovascular disease and brain disease. Okay. Before we start or decide to treat a patient, we need to look on the risk factor for this patient. For example, we have patient with high risk factors. We have patient with a major event of cardiovascular disease. So we have two main group of patients here. We are going to speak about that. So who is considered like major atherosclerosis risk factors? Okay, let us speak about the major atherosclerosis cardiovascular disease. This group of patients warrant to start statin. We have recent acute coronary syndrome with the past 12 months. Patients suffer from history of myocardial infarction, history of ischemic stroke, symptomatic peripheral artery disease. So all these considered like major atherosclerosis cardiovascular disease, acute coronary syndrome, MI, ischemic stroke, peripheral artery disease. Who's at risk of cardiovascular disease condition, at high risk? We talk about age. Okay, we are talking about age. If the patient suffers from familial hypercholesterolemia, diabetes mellitus, hypertension, chronic kidney disease, CKD, current smoker, history of congestive heart failure, history of peripheral artery bypass surgery or percutaneous coronary intervention, persistent elevated LDL cholesterol more than 100, despite maximally tolerated statin therapy. So we prescribe statin, we add ezetimibe, but the LDL remain higher than 100. So this one considered like high risk factor. So I will repeat it: age 65 and above, familial hypercholesterolemia, diabetes, hypertension, CKD, current smoker, history of heart failure, chronic history of artery bypass surgery, percutaneous coronary intervention, LDL more than 100 despite treatment with a maximum dose of statin and ezetimibe. Okay. So what is the treatment? What is the treatment for treatment goal or the protocol for the treatment of dyslipidemia? We start with the non-pharmacological approach, as you can see here, and this consists of two main parts. Number one, non-pharmacological therapy. We recommend patient to follow lifestyle modification, and next we move to the pharmacological therapy, which includes statin, bile acid resin or sequestrant, niacin. Then we have fibric acid derivative, cholesterol absorption inhibitor, fish oil, and new agent involved in the market. Okay, therapeutic lifestyle modification considered like first line intervention to lower lipid or lower hyperlipidemia should be implemented to all patients. We don't have exclusion here. We have some cases we don't wait, we start directly with the medication. This in addition to the lifestyle modifications. If the patients are from genetic familial hypercholesterolemia, always start with the medication. We don't wait until the patient, okay, go with the lifestyle modification for 6 months, 1 year. No. If the patients are from genetic familial hypercholesterolemia, start with the medication as soon as possible, in addition to the diet. Drug therapy, in addition to the diet, is warranted for this case, genetic familial hypercholesterolemia. This is not only related to the lifestyle, this is related to the something abnormal genetic maybe process in the human body. We need to address that by medication. Okay, alcohol can cause significant increase in triglyceridemia. So this one very important. If the patient alcoholic, and the situation will be associated with the elevated level of triglyceridemia and increased hepatic secretion of VLDL. VLDL mainly related to the elevated level of triglyceride. Synthesis and secretion of VLDL are increased by excess calories. When you have a lot of calories, this will lead to the increased level of LDL. So when you take a lot of calories, this will lead to the increased level of VLDL. Alcohol associated with the increased level of VLDL again. Okay. A therapeutic lifestyle change, we recommend patients to limit alcohol caloric from the fat to 20-25% daily intake, limit saturated fat less than 7%, cholesterol less than 200 milligram per day, use monosaturated fats, weight reduction if overweight or obese, increase physical activity, increase intake of soluble fiber, avoid or quit tobacco use. So all these consider lifestyle modification. General recommendation: limit calorie from fat. Number one. Number two, limit saturated fat to the 7%. Total cholesterol intake less than 200. Encourage use of monounsaturated fat. Reduce weight in obese and overweight. Increase physical activity. Increase intake of soluble fiber, and quit tobacco use. Okay, so we done with the first part with the non-pharmacological approach, lifestyle changes, TLC. Now we're moving to the pharmacological treatment, antihyperlipidemic drugs, pharmacological therapy of hyperlipidemia. Let us speak pharmacology now. So we need you to be familiar with a group of medication. We start with the statin. We start with the statins, as you can see, and statin belongs to the group of medication called HMG coenzyme A reductase inhibitor. HMG CoA reductase inhibitor, statin. Then we have niacin. Then we have bile acid sequestrant, number 3. We have fibrate. We have cholesterol absorption inhibitor. Number 6, we have omega-3 fatty acid. We have other emerging agent, number 7. So as you can see here, we have 7 main groups: statin, niacin, bile acid, fibrate, cholesterol absorption inhibitor, omega-3, and other emerging agents. We are going to discuss this group of medication together. Okay. This one here, you can see we have 1, 2, 3, 4, 5, and we have 6. We look on the effect of this group of medication on LDL. We look on the effect of this medication on HDL and on triglyceride. It's very important to look on these variables here, because according to this effect we can decide which one of these medications more effective on the LDL, HDL, or the triglyceride. Okay, so I will start my question here. Which of these, so here in this one here, I'll speak about statin. This is statin here. Fibrate, then we move on. So you can see here the question now: which of these agents most effective in lowering LDL? We have PCSK9 inhibitor. You can see how many arrows. We have 1, 2, 3, 4, 5 arrows. Okay, which one will be the second in effective lowering LDL level? Statin. So how many arrows we have? We have 4 arrows. So the most effective will be PCSK9. The second on the list will be statin to lower LDL level. Followed by number 3, followed by bile acid sequestrant. Number 3 on the list. Talk about efficacy here. So if you talk about efficacy, number 1, PCSK9, followed by statin, then at the end we have bile acid sequestrant. Okay, moving to the HDL. So we need to increase HDL, not decrease. So the purpose here to decrease LDL and increase HDL in the treatment. So if you ask the question now, which of these medication most effective in increasing HDL? So the most effective medication in increasing HDL will be niacin. Okay, so if you answer niacin will be the most effective. Who's the next on this list? Most effective medication for the increased HDL, niacin, followed by fibrate. So we have two groups for the treatment or to increase HDL. I will repeat it. Niacin, the most effective medication to increase HDL, high density lipoprotein, followed by fibrate. That's great. Okay. Moving to the triglyceride. Triglyceride, the question now, which of the following medication, most effective medication in decreasing triglyceride? So if you answer fibrate, you are correct. The most effective medication in decreasing triglyceride will be fibrate, followed by niacin. So we have two groups of medications affect the triglyceride. We have number one, fibrate, followed by niacin as number two. Statin, only two arrows. So number one will be fibrate, number two will be niacin, number three will be statin. But we need to look on something important here. Can we look on the bile acid? The bile acid sequestrant increase level of triglyceride. So if you have patients suffer from triglyceridemia, the triglyceride high, we don't recommend to prescribe bile acid sequestrant because bile acid sequestrant increase level of triglyceride. Okay. Now we have another category for statin. We have some patients indicated for high statin intensity, another patient warrant for the moderate intensity, and the third group low intensity lipoprotein. We call this one category of statin. We have high intensity statin, moderate intensity, low intensity, high effective, moderate effective, low effective. And this depends on the medication name. This effect depends on the dosage of the medication. When you have high dose, that means more effective. Lower dose, less effective. I'm going to speak about that. What that means when you say high intensity? So when you say high intensity statin, that means this medication decrease. That means this medication decrease LDL by more than 50%. That's great. So high intensity statin lower LDL by more than 50%. Okay, example, we need example, rosuvastatin, 20-40 milligram. We need to remember the name, we need to remember the dose. Rosuvastatin, 20-40 milligram, consider high intensity statin, lower LDL by 50%. Followed by atorvastatin, 40-80 milligram, lower LDL by 50%. Please remember, atorva, rosuvastatin, rosova 20-40, then we move to the atorva 40-80. These two medication with the two doses, specific two doses here, consider like high intensity statin lowering LDL by 50%. Done. Moving to the moderate intensity, they said with the moderate intensity, this lowers LDL by between 30 to less than 50. Between 30, I would say, to the 50%. If you said less, it's more accurate. So this medication with the dosage lower LDL by 30 to less than 50% LDL. Medication name, we have rosuvastatin, we have atorvastatin, but look on the dose. They said rosuvastatin 5 milligram, rosuvastatin 10 milligram, between 5 to 10, 5 and 10 milligram rosuvastatin, lower cholesterol between 30 to 50%. The same apply. Moving to the atorvastatin. Atorvastatin, we double the dose compared with the rosuvastatin. Rosuvastatin 5-10, atorvastatin 10-20. Double the dose. If you multiply by 2, you can get the atorvastatin. So atorvastatin 10-20 will be reduced LDL by 30 to 50%. Simvastatin, double the dose here by 2. This will be simvastatin 20-40. The same, multiply by 2, then we have bravastatin 40-80, and this will decrease the LDL. So on. If you look on the last one here, betavastatin, we have lower dose. That means more effective. 2 to 4 milligram betavastatin, lower cholesterol between 30 to 50 milligram. Okay, with the this is a moderate. So I will repeat it. Rosuvastatin 510, atorvastatin 10-20, simvastatin 20-40, bravastatin 40-80, lovastatin 40, betavastatin 2-4 milligram. So we need to remember these doses here. Low intensity statin, lower LDL by less than 30%. We have simvastatin 10 milligram, bravastatin 10-20, lovastatin 20, flovastatin 20, betavastatin 1 milligram. The only one is like different from the other, betavastatin 2 to 4 for moderate, 1 milligram for the low intensity. Okay, this table here shows the effect of the antihyperlipidemic drugs on the LDL lipoprotein and the percentage and some side effect contraindication. And then we have a case study here. We can discuss the case study with you. So if you look what we have here on the left side, so the question now, which of these group of medication reduce LDL significantly? Most important reduction of LDL. So if you look on the LDL level with the effect of statin, around 55% maximum effect. So followed by bile acid sequestrants. So the most effective medication for lowering LDL, number one, statin in the practice is available oral, followed by bile acid sequestrant. Okay, 55 to 30%. Next question: which of these medications most effective in increasing HDL? So if you look on the increasing HDL will be nicotinic acid or niacin. For increased HDL, 35%. So the first important medication, the most important medication, niacin or nicotinic acid in increasing HDL. Okay. Followed by fibric acid. So niacin number 1 for HDL, followed by fibric acid number 2. For LDL, we have, I will go the another color here with the green color. For the LDL, talk about LDL, number 1 statin, number 2 bile acid sequestrants. That's great. Okay, what about side effect? They said statin associated with myopathy and increased liver enzyme. So we need to remember that. Statin increased myopathy, liver enzyme. For this reason, if the patient suffers from liver disease, we don't recommend to prescribe this medication. Okay, bile acid. This medication works on the GI system. For this reason, patients suffer from GI distress, constipation, decreased absorption of medication, drug interactions for bile acid. So the situation with the bile acid will be GI gastrointestinal symptoms, constipation, the abdominal pain. Nicotinic acid, we have flushing and headache. Hyperglycemia, increased level of glucose, increased level of uric acid, increased risk of gout. And with the niacin, we have GI distress, abdominal pain, hepatotoxicity. So you can see here with the niacin or nicotinic acid cause hepatotoxicity. This is number 1. Then they said statin cause hepatotoxicity. For this reason, we don't recommend to use statin with the niacin because both of them cause hepatotoxicity. Okay. Moving to the last one, fibric acid. Fibric acid causes dyspepsia, gallstones, myopathy, unexpected non-coronary heart disease death according to the WHO studies. Now we have the case study here. The case study is very important. It brings the case for the patients are from 45-year-old man, so from high level of LDL and low level of HDL, present to the primary care physician treatment for guidance. In addition to exercise and diet modification, which of the following agent would be provide him with the most efficacious improvement in the LDL level? So which one will be the most effective lowering LDL level medication on this list here? We have statin, we have bile acid, we have niacin, we have fibratic acid. So the most effective medication in lowering LDL in the practice, in the clinical practice, according to the guideline, will be statin. So the most effective medication, or repeated, will be statin. Okay, we have some recommendation from the FDA. The FDA not recommend using simvastatin at 80 milligram a day, so we can use it less, 20, 40, 60. They found using simvastatin 80 milligram per day, this increased risk of myopathy and very rare case considered like life-threatening case called rhabdomyolysis. So simvastatin by dose 20 milligram, okay, not recommended by the FDA due to the risk of myopathy and rare rhabdomyolysis. What is rhabdomyolysis? This is very important to understand the definition for rhabdomyolysis. Rhabdomyolysis, they said, is like serious syndrome due to the direct or indirect muscles injuries. So the situation here with the simvastatin 80 milligram cause muscle injuries, muscle damage. So simvastatin 80 milligram cause muscle injury, result of death of muscle fiber, and release content of muscles in the bloodstream. This content of muscle in the bloodstream will arrive to the kidneys and cause kidney failure. So rhabdomyolysis lead to the kidney failure. Okay. Okay, after we discuss the pharmacological approach in general, we compare between groups. For example, we compare between statin, fibrate, niacin, bile acid sequestrant. Now we start talking about the individual group of medication. We're going to speak about statin, about fibrate, about niacin, and so on. So we'll start with the first group of medication. Here we have HMG coenzyme A, coenzyme A reductase inhibitors. So the main medication here we have statin, the main medication. We are speaking about statin. So they said statin, competitive inhibitor of HMG coenzyme A reductase. So the target for statin will be enzyme called HMG coenzyme A reductase. This enzyme responsible for synthesis of cholesterol. So when you inhibit this enzyme, the result will be inhibit synthesis of cholesterol and lead to the consequences. Moving to the other effect, decrease oxidative stress and vascular inflammation. That's great. So we have oxidative stress. This medication decrease oxidative stress and decrease inflammation. So if you remember, if you go back to the atherosclerosis, you remember we have inflammation there. So statin decrease inflammation. Okay, statin, if you remember what we have, oxidized LDL. Okay, statin decrease oxidation. So we have several benefits from the statin, not only lipid. So you can see here decrease cholesterol synthesis, number one, decrease oxidation, decrease inflammation. So we have several beneficial effects of using statin in patients with the cardiovascular disease, not only lipid. So here we need to emphasize these topics here. Not only the statin be used to decrease lipid and LDL, but also used to decrease inflammation and decrease oxidation. Okay. Increase stability of atherosclerosis lesions and decrease risk of migration of clots. Statin used as initial therapy immediately after acute coronary syndrome regardless of lipid. Any patient come to the clinic or to the hospital suffer from acute coronary syndrome MI and the patient discharged from the hospital, the patient will be placed on statin due to the beneficial effects explained already. Okay, how the medication work, how the statin work, you can see here the benefit. Number one, we inhibit HMG coenzyme A reductase, inhibit cholesterol synthesis and inhibit hepatic cholesterol synthesis. Okay, increase number of LDL receptor and the liver, the clear LDL and VLDL from the blood. So we have 4 steps. Number one, inhibit the enzyme, inhibit cholesterol synthesis, increase number of the receptor, clear LDL, VLDL from the blood. Let me share the screen with you. This one coming from Quizlet, Farm Lipid Drugs. Someone maybe bought it there, and I would like to share the information. You can see here we have a lot of review, and you have the figure or image here. If you click on this image, we try to maximize the image a little bit to show you what we have there. Okay, so you can follow with me the mouse, maybe the pointer here. Number one, they said the statin inhibit HMG. You can see here. I think we have another one much better. This one here come from another presentation published in Philadelphia University. You see the mechanism of action here. I'm not sure if I'm able to write here. No, I'm not able to write on the screen. So number one, the mechanism of action, you can remember we have 4 mechanisms of action. Number one, we have the statin inhibit enzyme coenzyme A, and this prevents synthesis of cholesterol, number one. Number two, will lead to the lower cholesterol, intracellular cholesterol. This will lead to the increased number of the LDL receptor. Okay, increased LDL receptor will increase number of receptor and promote uptake of LDL, bind to the LDL. This will lead also to the decreased VLDL in the plasma and increase it in the cellular level. So you can see it here, inhibit the enzyme, increase receptor, increase hepatic cholesterol synthesis. So number one, I will repeat it. Number one, inhibit the enzyme, decrease cholesterol, increase number of receptor, and clear the LDL, VLDL from the circulation. Okay. Half-life for the medication, the range, the half-life for the medication, most of the statin between 1 to 3 hours. We have only 3 medication, A, B, R, atorvastatin, pitavastatin, rosuvastatin, a long half-life between 12 to the 19 hours. So atorvastatin, pitavastatin, rosuvastatin, long half-life. And this weren't for the taken any time during the day, morning, evening, or without food or with food. A clinical use for the statin, clinical use decrease LDL cholesterol, number one, decrease risk of coronary artery event and mortality, decrease risk of ischemic stroke, and statin considered effective and well tolerated. So you can see here we can prescribe for the patient, we prescribe statin for the patient suffer from high level of cholesterol. We can prescribe it to the patient suffer from coronary arteries. We can prescribe it to the patient suffer from ischemic stroke, and this medication is considered effective and well tolerated. Okay. They said, according to the clinical use, in a human body, cholesterol synthesis takes place during night. So the human body starts synthesize cholesterol during the night. Statin recommended to be administered in the evening. So statin recommended to use or administer during the evening, with exception of atorva, rosova, and pitavastatin. If you remember A, B, T, consider you can give it any time during the day or evening, morning or evening. There is no change, with exception. but otherwise maybe statin should be given in the evening, because statin cholesterol synthesized during the night. A statin contraindicated during pregnancy because the statin considered like teratogenic effect. Statin have teratogenic effect on the fetus. Okay, now who is going to benefit from the statin? We have four main groups will benefit from statin. We need to prescribe statin. Number one, patient with LDL cholesterol more than 190. So you have patient come to the clinic and you measure LDL, fasting LDL, and the fasting LDL 190. This is a patient for the statin. Number one. Number two, patient with the atherosclerosis cardiovascular disease. We're going to mention that. Who's next? Patient with between 40 to 75 years old, 10 years risk factor more than 7.5% for atherosclerosis risk factors. You need to calculate that. Look on the data here. Patient aged 40 to 75 years with the diabetes, even with the LDL normal, but without cardiovascular risk factors. Here they start talking about diabetic patients should start with the statin. Even the LDL level is between 70 to 189. Between 70 to 189, this is warrant for the treatment. So if you have LDL level, for example, in diabetic patients like 70, 80, 100, okay, we will start with statin. This is a leaflet or like flyer available on the website from the American College of Cardiology. You can see the four statin benefit groups. Number one, clinical atherosclerotic cardiovascular disease. Then we have anyone with a LDL more than 190, equal or 190. Okay, any patient with between 40 to 75, diabetic patient, and the LDL between 70 and 189. Number three. And number four, here we have patient with when we have atherosclerotic cardiovascular disease more than 7.5%. We can calculate atherosclerotic cardiovascular disease. Okay, this one from the American College of Cardiology, atherosclerosis cardiovascular disease estimator plus. For example, you can type the age. I will work with you here because when you said more than 7.5%, this is warrant for the statin therapy. I will type the age. We'll say here 55, male, race. I will say, I will go the other. I will type here white. Systolic blood pressure. I will type 125. Diastolic. Okay, 80, or I would say 79. Total cholesterol 199. LDL 45. Okay, LDL cholesterol, I will type here like 100. Smoking, yes, normal, never. History of diabetes, no. History of hypertension, yes. On statin, no. Aspirin, no. Do you want to refine current? Okay. Now, if you look what we have here for the patient, the risk factor for atherosclerosis, 6.8 for the current 10 years. So if you change, for example, I will change this one to the smoking person, current smoker. You can see the risk factor 12.6. Increase risk factors. If you said no, okay, roughly 50% will be dropped. Do you use aspirin? Yes. Statin? Yes. Okay. Current smoker 12%. There's no change. Hypertension? Okay. Maybe increasing hypertension increase risk of cardiovascular disease. So you can go to the American College Cardiology or calculate atherosclerosis cardiovascular risk factors. Okay. So what we have here, the purpose of this one to go a little bit in more detail. They said if the patients are from cardiovascular risk factors, we look on the age. If the patient less than 75 and he has clinical car- atherosclerosis cardiovascular disease, if you go to the previous slides, and less than 75, start with high intensity statin. If the age less 75, start with high intensity statin. If that's age more than 75, talk about elderly people here, start with moderate in order to avoid side effect. Moderate statin intensity. If the LDL level more or equal 190, goes with high intensity statin. If the patients are from diabetes, depends on the situation or age, but type 1, type 2 diabetes, 40, 75 years old, 70, 89, 10 years, 7.5, more than 7.5, or 10 years, more than 75. So start with moderate, high intensity, or high intensity. Consider statin if the age less than 40 or age less than 75. Final one, if the patient between 40 75 and risk factor 7.5%, 10 years, consider high moderate intensity therapy. So not only everyone, could be someone with a normal lipid will start with statin. Even the lipid is normal, we will start with statin. Here we move to the hepatotoxicity, or like we talk about adverse drug reactions or toxicity. A statin may cause hepatotoxicity, myopathy, rhabdomyolysis in rare cases, rare event. Risk factor for rhabdomyolysis include renal insufficiency, we explained that, vitamin D deficiency, hyperthyroidism. All these increase risk of rhabdomyolysis. Advanced age, female, and use another drugs that interfere with the muscles, adverse effects such as niacin, for example. So niacin increased risk of toxicity and statin increased risk. We don't recommend to use it together. So hepatotoxicity could be mild elevation in aminotransferase. It's common in the treatment. You can see some patient myopathy, increased creatine kinase as indices of muscle disease, rhabdomyolysis. So we have three main symptoms as adverse effect of statin. Common symptoms: hepatotoxicity, myopathy. Rare event will be rhabdomyolysis. We discussed it in the previous slide. Statin and drug interactions is statin metabolized by the cytochrome B450. Drugs or food inhibit cytochrome B450, increase risk of hepatotoxicity and myopathy. So statin, we type it here, statins, okay, metabolized by the enzyme cytochrome B450, okay, this will lead to the decreased level of statin in the blood. This is a normal effect. If the patient use any medication or food that inhibit this enzyme, any medication or food that inhibit this enzyme, this will lead to the, okay, any medication or food that inhibit this enzyme, this will lead to the increase or prolonged effect of statin. Prolonged effect of statin, that more toxicity. Okay. Then they start talking about metabolism. They said 3A4, cytochrome 3A4 is metabolized lovastatin, simvastatin, atorvastatin, LSA. So 3A4, this is a very popular cytochrome in the liver, in the population. Cytochrome 3A4, responsible for metabolism 3 statin. Number 1, lovastatin, simvastatin, atorvastatin, and the first letter for each medication start with L: lovastatin, simvastatin, atorvastatin. 2C9, we have flavastatin, Betovastatin, rosuvastatin, and the last one, Solvation, we have bravastatin. So I will remember the first one here with the 3A4. I will remember Solvation for the last one, and the rest will be to the 2C9. So this enzyme very important. We have some example here for the drug interaction. Here we talk about drug interaction, DI. 3A4 reduce inducers. We have something enhance, accelerate. Example, phenytoin, crisosulfan, barbiturate, rifampicin, and thiazolidinedione accelerate 3A4. I will repeat it. Phenytoin, crisosulfan, barbiturate, rifampicin, thiazolidinedione. This is induce, accelerate 3A4. This will lead to the decrease plasma level of statin, because accelerate. So when you have acceleration, decrease plasma. We have some inhibitors for this enzyme 3A4. Some inhibitors such as macrolide, cyclosporin, azole, tacrolimus, paroxetine, for example. We have fibrate, grapefruit juice. So all these inhibit the cytochrome 3,4. So the result will be increased statin in the blood, accumulate. So the question now, which one will be lead to the increased level of statin in the blood? So we can put the question there. For example, macrolide. Okay, I will type here phenytoin. I will type also here, for example, I will go with the paroxetine. Okay, which of these medication, let me type another one, rifampicin. Okay, which of these medication increase level of statin in the blood? Which of these medication increase level of statin in the blood? You need to remember this one induce cytochrome. Phenytoin induce cytochrome. It's not correct answer. Macrolide inhibit the cytochrome, lead to the increase, and paroxetine inhibit the cytochrome increase. So the correct answer will be, okay, the correct answer will be paroxetine and macrolide. Okay. So I think it's a very good example here. They said a grapefruit juice, also grapefruit juice inhibit the metabolism, and this will lead to the increased level of LSA, lovastatin, simvastatin, and atorvastatin. Regarding 2C9, we have azole, metronidazole, sulfenibrazole, amiodarone, or amiodarone, cimetidine. This group of medications, what happened here? Inhibit 2C9. So 2C9 responsible for the rest of medication, like fluvastatin, rosuvastatin, and the result will be increased level of fluvastatin and rosuvastatin, azole, metronidazole, sulfenibrazole. Question: which of the following statin utilize the enzyme 3A4? Select all that apply. 3A4. Which of these? Simvastatin, fluvastatin, lovastatin, atorvastatin, rosuvastatin, and bravastatin. I will go back to refresh our mind a little bit. LSA 3A4. LSA, LSA metabolized by 3A4. This is the correct answer. Select all that apply. Bravastatin, Solvation. This one, rosuvastatin, flavastatin, will be 2C, what do you think, 19 or 9? 2C9. Okay. Fluvastatin and rosuvastatin. Which statin is not metabolized by cytochrome system and would not be affected by inducer or inhibitor 2C19 or like cytochrome B450? Fluvastatin? No. Rosuvastatin 2C9. This one 3A4. Bravastatin, fluvastatin 2C9, So the correct answer will be bravastatin. So not metabolized by the cytochrome. I go back to show you what we have. Okay, salvation here, bravastatin. Okay. 6-year-old case study here. Case study: 6-year-old woman presents with a chest pain radiating to her left arm, diagnosed with a myocardial infarction, and prescribed statin medication. How does inhibit HMG reductase cause a lower cholesterol LDL level? How? If statin inhibit the HMG CoA, this will lead to the lower LDL cholesterol. We ask about what is the mechanism. Number one, increased level of HDL in the blood. Number two, decrease serum level of LDL by promoting catabolism. Number three, inhibit formation of LDL and from IDL. Inhibit cholesterol synthesis or inhibit synthesis of LDL receptor. So the correct answer here, the correct answer will be inhibit cholesterol synthesis. So by inhibit HMG coenzyme A reductase, this will lead to the inhibit cholesterol synthesis. Inhibit cholesterol synthesis, this is number one. This is number two, inhibit cholesterol synthesis. Number three will be increased number of LDL receptor. So you can see here inhibit, it's not inhibit, should be induce, increase. This is not correct. So the correct answer will be, I'll clean everything here. The correct answer will be inhibit cholesterol synthesis. Okay, case study. 55-year-old Caucasian male with a history of hypertension, management with a daily lisinopril. He is his current smoker. He wishes to explore the option of statin therapy. His fasting lipid profile: cholesterol 227, LDL cholesterol 160, LDL 47, triglyceride 100, fasting glucose 92, and blood pressure 120/82, heartbeat 70. Calculate the estimated risk factor. So we can click on this one and we calculate the risk factor for this patient. So this one consider like activity, and we recommend you to follow this one and calculate the risk factor for this patient. And you can see here we have the information here. Based on the above information, category for this patient: 10 years, low risk factors, or borderline, intermediate, or high risk factors. So what do you think here? The patient, we have the data here, we have the number here. So what do you think the patient will be in which category? Intermediate risk factors? You are correct, because we have the data there and we have all the data and filled in the table. Okay, so we're done with the first group of medication. We discussed statin with you, and if you go back to the slide again, that's a quick review for the statin. So you can see here we have the statin, how this medication work. Number one, inhibit the enzyme, increase LDL by 30 to 55%. Oxidative stress, anti-oxidative stress, anti-inflammatory effect. The mechanism of action, we need to understand the mechanism of action. Which one's long half-life medication, for example. We discussed how this medication, the benefit of a group of medication. And this medication could be given at night, but we have some exemption: atorvastatin, pitavastatin. This medication teratogenic during pregnancy. Who's going to be benefit from the medication? So we have it here. Who's going to prescribe high statin or moderate statin? For example, less than 75, go with high statin. More than 75, go with the moderate statin, and so on. Moving to the next medication now, bempedoic acid. And the bempedoic acid, this is a new medication, work, and the brand name Nexletol, the brand name for the bempedoic acid. This medication work by inhibiting enzyme called ATP, it stands for adenosine triphosphate citrate-lase inhibitor, adenosine citrate-lase inhibitor, ACL. And when we have this asterisk, that means we have more data. A recently approved oral inhibitor of ATP citrate-lase. By inhibit this enzyme, this will prevent production of cholesterol upstream from the HMG-CoA enzyme reductase inhibitor. They found this medication, bempedoic acid, decreased LDL cholesterol by 15 to 20%. If you compare that with the statin, and you remember that statin between 30 to 55%, and some data said 50%. So it depends on the situation. More effective statin, we have bempedoic acid decrease LDL by 15 to 20%. This medication, the advantage of bempedoic acid, does not cause muscle symptoms. This is the advantage here. So statin causes myopathy. Here, bempedoic acid does not cause myopathy. Bempedoic acid causes hyperuricemia, increased uric acid in the blood, and tendon ruptures. So we have to take this in consideration. If the patients are from gout or like hyperuricemia, we don't recommend to use this medication, for example. Okay, this medication approved to be combined with the statin. For example, you place your patient on statin and increase the dose to the maximal dose, but we still need to add some medication to control hyperlipidemia. We can add Nexletol to the statin. And patient with established cardiovascular disease, hypercholesterolemia, familial hypercholesterolemia. So if the maximum dose is not enough, we add bempedoic acid to the treatment. Let me share the screen with you from the bempedoic acid, the website for Nexletol. And you can see here we have Nexlizet, bempedoic acid with ezetimibe. We have bempedoic acid alone, Nexletol. And this is a medication work with a clear harmony. And they show us the effect of medication, add efficacy, add power, add Nexletol. They said when patient with a atherosclerotic cardiovascular disease, heterozygous familial hypercholesterolemia need additional lowering LDL on the top of the diet and maximal tolerated statin therapy, adding Nexletol, and they found here the harmony and wisdom, and what they found here, the additional reduction by 18 to 17% of the lowering LDL. So this is important topics here to look what we have. Okay, I will clean this one and focus on some important things for you. So you can see here, this is add effect in lowering LDL. Next we have this one here, another link to look what we have, any data we have there. Okay, we look on the data to show you what we have. We have bempedoic acid, and this is approved by 2020. I will make it bigger a little bit. Indications, adenosine triphosphate citrate-lase inhibitor, indicated for as adjunct therapy in addition to diet, and statin therapy. For the treatment of primary hyperlipidemia in adults with heterozygous familial hyperlipidemia or atherosclerotic cardiovascular disease who require additional lowering LDL. This medication available 180 once daily. So You can see now we discussed this medication. It's like we start with the statin, maximize the dose in addition to the diet, and this is number one, diet, and number three, we have go with the combination treatment. Bempedoic acid, if you click on this one here, I click on, okay, I will go to the website again, Bempedoic acid, how this medication work. And this is the article published in Duff Press Publisher, Bempedoic acid for the heterogeneous familial hypercholesterolemia. Okay, and we have the image here. If you click on the image, okay, this gives us the how this bempedoic acid work. So bempedoic acid mechanism of action, they found this is bempedoic acid. So bempedoic acid inhibit the first conversion of citrate to the acetyl coenzyme A. Inhibit conversion of citrate to acetyl coenzyme A. Then we have statin. Statin inhibit HMG coenzyme A reductase. So the result will be decrease upregulation. Number one. So when you inhibit synthesis of cholesterol, so number one, inhibit synthesis of cholesterol. This will lead to the increased number of LDL receptor. Upregulation of the LDL receptor mean increased number of LDL receptor. This will increase LDL clearance and decrease plasma LDL. So the end result will be decreased plasma LDL. Okay. You can see here with a clear harmony, they said this medication decreases 15% of the LDL when you add it to the statin compared with the placebo. Okay, so already we have already covered the four topics about hyperlipidemia, including we started with the statin, then we moved to the next group of medication, bile acid raising or bile acid sequestrant. We explained the niacin, how the niacin work, what is the side effect for niacin. Then we spoke about fibric acid derivative or like fibrate. Then we have another two or three major group. The first one, cholesterol absorption inhibitor. Then we have omega-3 fatty acid and new emerging drugs. So talking or speaking about the cholesterol absorption inhibitors, as you can see here, okay, cholesterol absorption inhibitor, we have ezetimibe. Ezetimibe inhibit cholesterol absorption. You can see here in the slide. So ezetimibe, the mechanism of action, inhibit cholesterol absorption in the small intestine, and this will lead to that decrease LDL by 15 to 24%. So the average around 20%. The average reduction of LDL about 20%. And how this medication work? This medication work on the small intestine by inhibit reabsorption of cholesterol. This medication, because you can see the percentage of lowering cholesterol is like low percentage, and if you remember with the statin lower the LDL by around 50 to 55%. Considered like the most effective medication for lower LDL. Therefore, they said this medication, ezetimibe, could be considered like preferred adjunct therapy in combination with the statin. So we can, for example, if the patient on a statin and the statin does not, for example, the LDL does not reduce effectively, we can add ezetimibe to the statin. Statin available as a tablet, 10 milligram tablet. You can see it here, 10 milligram tablet. 10 milligram dose for the ezetimibe, 10 milligram daily with or without food. Ezetimibe available as a combination with simvastatin or with atorvastatin, and we have the brand name Vytorin, and we have another brand name for atorvastatin and ezetimibe. Moving to the adverse effect, generally the medication well tolerated. Some patients suffer from upper respiratory infection, arthralgia, diarrhea, sinusitis, and extremities, pain and extremities. Okay, so we have here the link for the medication. We can click on the link and read information, and I encourage you to read the information about ezetimibe. Here, in this slide here, we need to focus on the exact mechanism of action of ezetimibe, Zetia, the brand name Zetia, how this medication work. They said this medication block something called NPC1L1. This is kind of transporter. I will read what we have here from the maybe from the prescription writing for the Zetia ezetimibe tablet, approved by 2002, and they speak about how this medication work. You can see the ezetimibe target. The ezetimibe target will be the transporter. This transporter called Neumann-Beck C1 like 1. So this abbreviation for that, NPC1L1. So this is kind of transporter. So what we have here, how this medication, and this one available in the brush border, in the small intestine. Okay, so what we have here is ezetimibe block the receptor NPC1L1, decrease absorption of the cholesterol from the GI system. So this is the main mechanism of action of ezetimibe. If I click on the, okay, let me share the screen with you to show you what we have there for ezetimibe. So you can see the receptor here on the screen, and we have the NBC1L1, and ezetimibe block the transporter, and this is a GI lumen or like gastrointestinal lumen, and we have the cholesterol. We have transporter responsible for this transporter responsible for absorption of cholesterol. By prescribing ezetimibe block, you can see the X here, block this transporter NPC1L1 and the lumen, and decrease absorption of
cholesterol and decrease LDL by maybe you can see the percentage there if you go back to the slide, 15 to 24%. Okay. Next medication, we have omega-3 fatty acid, the active lipid lowering component of fish oil. So omega-3 fatty acid, considered like the active lowering component available in the fish oil, are EPA and DHA, and this one stands for the two group of medication. Let me look on the group of medication and speak with you about that. Okay. So ABA and DHA, ABA stand for eicosanobenzoic acid, and DHA stand for docosahexaenoic acid. So it's long name. We prefer to go with the abbreviation, and this is kind of fatty acid, APA and DHA. APA, DHA increase lipoprotein lipase activity. Lipoprotein lipase activity is responsible for lowering triglyceride biosynthesis. So what we need to remember here, this enzyme responsible for metabolism of fatty acid or lipoprotein. So this lipoprotein lipase responsible for metabolism of lipoprotein. Lipoprotein lipase responsible for metabolism of lipoprotein. Therefore, the end result will be lowering triglyceride biosynthesis. So you can see here the abbreviation for ABA and DHA. How the main action for this omega-3 fatty acid, they said this group of medication reduce triglyceride and VLDL cholesterol. But on the other hand, this group of medication increase LDL cholesterol. So if the patient suffer from increased level of LDL, we don't recommend to prescribe omega-3 because omega-3 increase LDL. Okay, so but if the patient suffer from high level of triglyceride, this could be the ideal medication. Two prescriptions available for in the practice: omega-3 acid ethyl esterase and the brand name Lofasa, and another one it's like Faseba. So two medication, you can see the brand name here, Faseba. It belongs to the omega-3 fatty acid. This medication approved for treatment of high or very high, I will type here very high level of triglyceride, and they said more than 500 in adult. So when you have patient with a very high level of triglyceride, Faseba or Lofasa will be the maybe drug of choice for this patient. Faseba reduce rate of ischemic event by 25%, significantly reduce risk of cardiovascular death when compared with the placebo. Adverse reaction include irritation, dyspepsia, GI disturbances, increased bleeding time. Please remember this medication derived from the omega-3 from fish oil. This medication derived from fish oil. We have some people suffer from allergy to seafoods. So if the patient suffer from allergy to the seafood, we don't recommend to use omega-3 fatty acid. We don't recommend to use Lofasa or Faseba. So in this case, we need you to remember the list for the medication here. We have omega-3 fatty acid, we have Lofasa, we have Faseba. This medication very good option for the patients suffer from high level of triglyceride, especially above 500 milligram per deci in adults. This medication considered like contraindication if the patient suffer from allergy towards seafoods. So omega-3 fatty acid. This one here coming from the Faseba website for the articles. You can see here compare between they combined statin with the placebo in 4,000 patients. Another 4,000 patients take Faseba with a statin. They compare between Faseba effect and placebo effect, and you can see the cardiovascular event here. We talk about the primary endpoint for the cardiovascular event percentage, and you can see here the Faseba decrease cardiovascular event. If you go to the slide before, they said it's okay that this medication decrease is 25% of significantly decrease or reduce cardiovascular event. So you can see here around 25%. Okay. Okay, we have case study here for patient 64-year-old woman with a past medical history of pancreatitis, triglyceride 2,200 milligram. What do you think about triglyceride? Very, very high level of severe high triglyceride. The patient suffers from gout, uncontrolled gout, severe psoriasis, and the patient already on simvastatin, and the patient suffers from myopathy associated with simvastatin. Her current medication includes rosuvastatin, prednisolone, allopurinol, and colchicine for the gout exacerbation. Okay, so the patient report anaphylactic reaction to the eating seafood in college. Her LDL level 96, HDL 42, triglyceride 640, triglyceride 640, high triglyceride. Which of the following is the safest addition to her therapy? Rosuvastatin, because the patient already suffers from myopathy and she is already on some lovastatin. It's not this one. So our target here, the action, our main action here, we're looking for medication to lower triglyceride. So her previous triglyceride 2200 and her current triglyceride 640. So the question, what is the normal range for triglyceride? This one should, the normal range for triglyceride, if you go to the previous slide, 150. And the patient triglyceride 640. That means the patient suffers from severe hypertriglyceridemia. So that triglyceride is very high in this patient. So we're looking for medication to lower triglyceride. Niacin is good for triglyceride, but it's not like maybe most potent medication. Could be used, but not the first choice. We put a question mark. Colicivilam, it's not for the triglyceride. Faceba, fenofibrate, rosuvastatin. What do you think? Okay, speaking about the Faceba here, shall we go the Faceba here? If we said no, you are correct. And the reason we don't use Faceba is like fish oil. We don't use Faceba because the patient has a history of allergic to the seafood. So now we cancel Faceba. We don't use rosuvastatin. That's great. What else here? The patient suffers from gout. And if you go back, you can see niacin involved in inducing gout. So we don't use niacin. That's great. So we have now two medications, colicivilam and fenofibrate. Colicivilam mainly reduce, if you talk about colicivilam mainly reduce cholesterol. So it's not for the triglyceride. So the only one for the triglyceride appropriate for this patient will be fenofibrate. Okay, during pregnancy, what we can do? What they say there, they found cholesterol and triglyceride level rise progressively during pregnancy. Drug therapy should not continue during pregnancy. We prefer to stop therapy. Statin considered category X, teratogenic. Statin considered like teratogenic during pregnancy. It's not contraindicated during pregnancy. And if the patient if the patient is very high risk of hyperlipidemia, cardiovascular disease, we can use bile acid resin, because this medication considered like a local medication, local effect, and not absorbed to the blood circulation. You can see no systemic drug exposure. Ezetimibe could be another option for the patient, but the first option, the best option for the patient will be bile acid resin. So during pregnancy, not allowed to prescribe statin. Ezetimibe the second option. So the first option will be bile acid, okay, resin, and the second option will be ezetimibe for during pregnancy. Okay, treatment guidelines. This is coming from American Heart Association 2019. Okay, we have the journal here. I recommend you to click on the link and read the information. This is coming from the Journal for American Heart Association, and we have information there. And if you go to the slide, I believe we can click on the link. Okay, let me share the screen with you from the website, and you can see here the journal, circulation journal for American Heart Association. What we have here, they study the primary guideline on the primary prevention of cardiovascular disease. If you scroll down to look on the guidelines, a lot of information there.
Okay, the only one available for us to follow. Okay, for the primary prevention, you can see the primary prevention here, figure 3, primary prevention. If you maybe maximize the image, try to make it on the same page. Okay, we can see the situation here for primary prevention. We need, first of all, we need to assess atherosclerosis risk factor in each age group, emphasize adherence to healthy lifestyle. So it's very important to maybe encourage healthy lifestyle, and we look on the patient age between 0 to 19 years old, between 20 to 39, between 40 to 75. We look on the LDL level, for example. We look on the atherosclerosis risk factors, less than 5%, low risk factors 7 to 7.5, borderline risk factor, intermediate 7.5 to 20%. Then we have high risk factor of more than 20%. Okay, so we already discussed it, and we recommend you to read this article. The process to start using the medication is very important. Okay. Moving to this one, 2019, the article published in 2019. New emerging drugs. New emerging drugs, we have three main medications, but on the list we can see 1, 2, 3, and 4 medications on the table. For example, we start with the MTP inhibitor and lometabid. We have lometabid, Jaxabid. If you like to remember, lometabid, MTB, and for the MTB, we have MTB here, lometabid, MTB inhibitor, lometabid, brand name Jaxabid. Then we have ApoB, ApoB100 synthesis inhibitor. We have Mebomersen, Kynamro. Okay, ApoB100, Mebo. So remember this one here, we have Abo. Then we have BCSK9. This is a PCSK9 inhibitor. We have MAB, Evolocumab, Repatha. Then we have Alirocumab, Proluent. So we have three group medication, as you can see. The first one, MTP inhibitor, lometabid, ApoB100 synthesis inhibitor, Mebomersen. Then we have PCSK9 inhibitor, Evolocumab, Repatha, Alirocumab, Proluent. It's very important to look on how we can use this medication. This therapy is reserved for patients suffer from familial hypercholesterolemia. So we are talking here about genetic hypercholesterolemia, number one. Number two, this medication could be prescribed to the patient suffer from atherosclerotic vascular disease who do not respond adequately to the other regimen. So the patient already placed on statin. And if we don't have enough response, we add ezetimibe, for example, or we can add fenofibrate, or we can add bile acid resin. If the patient does not respond to these strategies here or regimen, the next step will be moving to a new drug formation like MTP inhibitor, lometabid, Mebomersen, Repatha. So it's not first choice for us. So this one is reserved for patient not response to the medication in the guidelines. Statin, ezetimibe, bile acid, fenofibrate. The patient did not respond to this medication, we move to the new medication. Mepomersen, Lomitabid, Rebata. How we can remember the situation here? As you can see here, we have new drug for dyslipidemia,
and again, this is not the first choice. This is could be like adjunct therapy for the patient. But what is important for this medication? If you look on the Rebata, for example, Rebata decrease LDL level between 51 to 71. The most effective medication, if you look on the arrow here, in decreasing LDL like 5 or more, decreasing LDL level. Like the most effective medication in decreasing LDL, Rebata, Evolocumab, followed by Alirocumab, 45-58%. Okay, moving to the next, this one could be the Lomitabid, Juxtabid, work on the MTB inhibitor. And the first one, ApoB100 synthesis inhibitor, Mepomersen, Kenamro. And you can see the first one, Kenamro, come like pre-filled syringes, need instruction how to use the syringe. Then we have Lomitabid coming like Juxtabid capsule. Then we have Rebata, single dose syringes. Then we have Alirocumab. Then we have Evolocumab, Rebata pre-filled syringes. So we have 4 group of medication. I will start with the first one, ApoB100, how this medication work. This medication inhibits production of ApoB100, and we need you to remember for the LDL lipoprotein, we have receptor on the ApoB100. This receptor called ApoB100. So Mepomersen, okay, inhibit this receptor. So inhibit production of ApoB in the liver. This will lead to the decrease LDL and VLDL and decrease it by 21%. This medication could be considered like adjunctive therapy for patients suffer from familial hypercholesterolemia. The Mepomersen associated with the black box warning of hepatotoxicity. Considered during pregnancy. B, during pregnancy, could be prescribed safely during pregnancy, Mepomersen. Mepomersen may cause active liver disease, hepatotoxicity. Moving to the next medication, Lomitabid, Juxtabid, and available capsules. MTB inhibitor, decrease cholesterol 40% and triglyceride 45%. Adjunctive therapy for familial hypercholesterolemia, genetic, and this medication inhibit this enzyme and lead to the decreased LDL, VLDL, and again associated with the hepatotoxicity. But for the Juxtabid, Lomitabid, considered like category X during pregnancy. This one is not allowed to use it during pregnancy. This one we have, okay, we can use it because category B. So Mepomersen, Kenamro, we can use it during pregnancy because it's category B, could be safe in a human being. So the last one as a new drug for dyslipidemia, PCSK9 inhibitors. Okay, let me look on the just 1 minute what that means for us. Okay, saying about PCSK9 is PCSK9 stands for like proprotein convertase substituting casein protein found in the liver. This protein assists in degradation of LDL receptor. So again, this protein responsible for degradation for catabolism of LDL receptor. So this protein responsible for degradation of LDL receptor. If we inhibit this protein, this will lead to the increased LDL receptor. So monoclonal antibody, from the name, Alirocumab, Evolocumab, considered like from the name monoclonal antibodies, bind to the PCSK9, prevent PCSK9 from binding to the LDL receptor. This will lead to the increased number of LDL receptor, remove LDL particle from the circulation, and decrease LDL from the circulation. So we have images for that, and you can follow the information through that process. Any side effect? They said the only side effect for this medication for PCSK9, hypersensitivity reaction, and nasopharyngitis and influenza-like symptoms. PCSK9, you can see here, they only try to show us what we have. Okay, so as you can see for PCSK9 inhibitor here, PCSK9 stands for the protein convertase substrate CECN9 abbreviation. This is protein or enzyme found in the liver. Enzyme, I prefer to call this one enzyme because convertase enzyme, protein enzyme found in the liver. This is the liver here. Okay, this enzyme responsible for degradation of LDL receptor. So if you inhibit this enzyme, this will save the LDL receptor, increase number of LDL receptor, increase LDL receptor in the surface. So what we have here, this represents the LDL receptor, and then we have the LDL receptor here. You can see the LDL receptor. So the LDL binding to the receptor, what they found, we have PCSK9, this small particle here responsible for degradation of the receptor, destroy the receptor, the PCSK9. When you prescribe Repatha or Broluent or Alirocumab, this is a fully human monoclonal antibody. When you prescribe it to the patient, the Evolocumab binding to the PCSK9 inhibit PCSK9. This will lead to the increased expression of LDL receptor, keep the LDL receptor alive and binding to the more LDL from the circulation and decrease level of LDL in the circulation. We have patient here, case study, 4.5-year-old boy. His checkup, the pediatrician noticed the cutaneous xanthomas and ordered lipid panel. Repeated measurement confirmed that the patient's serum cholesterol level, so you can look on the cholesterol level, 936 milligram. What do you think here? Very high cholesterol. The patient on atorvastatin 40 milligram per day, a 5.5-year-old boy. Further testing confirmed the patient. This boy suffered from homozygous familial hypercholesterolemia, genetic hypercholesterolemia. Which of the following intervention will be the best or most effective in this patient? So the patient already on the atorvastatin 40 milligram. Shall we go with the simvastatin, ezetimibe, evolocumab, niacin, bravastatin? I will, for example, if you said simvastatin, it's not correct. Bravastatin not correct, ezetimibe not correct, niacin not correct. Severe high. So we need something to reduce the severe high level. So roughly between 51 to 71% reducing LDL cholesterol, the most effective medication. So the question now, which of the following will be the most effective therapy in this patient? This is the most effective. Can we use other? Yes, but the most effective will be evolocumab, Repatha. Okay, as a recap of our end of our lecture here about agent used in dyslipidemia or antihyperlipidemic agents, in our lecture we already covered the statin, different type of statin, different intensity of statin. We spoke about the hepatotoxicity as adverse effect, about the rhabdomyolysis, about myopathy. We covered the bile acid resin, and we spoke about niacin. Then we spoke about fibrate, another group of cholesterol absorption inhibitor, ezetimibe. Then we mentioned or we discussed the omega-3 fatty acid, Vasiba and Lofasa. And then we spoke about the new emerged medications such as Mibomersen, Lometabed, Evolocumab, Alirocumab, like a group of medication. In general, we discuss the main topics and approach of clinical pharmacology and cardiovascular effect. We discuss how this medication works. We discuss the mechanism of action. Number one, we discuss the action of this medication. Number two, also we discuss the clinical use of this medication. For example, we have some medication for hypercholesterolemia to lower IDL, most effective medication to lower LDL. And we discuss which one is the most effective medication to lower triglyceride. Which of the following medication on the list responsible for lowering the triglyceride or lowering LDL level, which one of these medications most effective in increasing HDL, for example. Then we discuss the adverse drug reactions. We discuss, for example, hepatotoxicity. We discuss the myopathy. We discuss the increased liver enzyme. We discuss the gallbladder stones, gallbladder stones. Some medication cause hyperuricemia. Then we discuss the pregnancy. Which medication should not use during pregnancy? Which medication we can use it safely during pregnancy? We discuss that with you at the end of this lecture. Thank you so much for your listening, and I hope you enjoy and you learn from this lecture. So I would like the student to learn from this lecture, to maybe understand the concept, apply the concept, and synthesize the information and use it in the clinical practice. And in this lecture we have a lot of example, a lot of questions, a lot of case study that help to understand and comprehend the concept of antihyperlipidemic medication or drug use in dyslipidemia. Thank you so much and have a great day, everyone.